Let's start. Today is talking about testing for genetic disease in the clinic. Let's say genetic testing because when you say genetic testing, probably people will think that we will test for the gene itself. But when we say testing for genetic disease, this is more broad. Sometimes you use biochemical testing to diagnose a genetic disease. And this term including, I want you to have the understanding of that you use multiple tools to diagnose a genetic disease. You are a physician in the clinic and you have a patient. Sometimes you will use testing for his genes. Sometimes you will use tools to test the product of the gene. And by knowing the product, you know that the gene is working well or not. These products could be enzymes, could be proteins, okay? So you don't need, and this you use biochemical testing. However, this biochemical testing will be used to diagnose a genetic disease. Sometimes we don't look for the genes itself. We look for the whole chromosome, cytogenetic testing. So a part deleted or duplicated in the chromosome. So this is cytogenetic testing. So we are talking about testing for genetic disease, not only genetic testing for the genes itself. Is a type of medical test that identifies changes in genes, chromosomes, or proteins. Their results can confirm or rule out a suspected genetic condition or help determine a person's chance of developing or passing on genetic disorder. So this is the context in the clinic. You want either to diagnose the disease in this person or tell him about having a risk of developing this disease or having a risk of transmitting a disease to his offspring. This is the disease. Now, if we ask, what is the time that we do genetic testing? In fact, we do it anytime. This is life cycle. My life cycle, it's not a real life cycle. We think, no, but this is just describing the stages of the life. Person will be born, child, adult, then they will marry, they will get pregnant, and they will have children. Okay? So, this baby, when delivered, sometimes he will be affected with genetic disease. Sometimes he will develop it when he is a newborn, or when he's a child, or when he's adult. At any stage, he could develop a genetic disease. Genetic disease, not always congenital. It could be congenital from birth. There is a problem. And it could not be congenital. It could be genetic but not congenital. Started at adult age. There is genetic disease that starts at adult age. So when do we perform the genetic testing? The common scenario as a pediatrician, I used to see a child who's affected with query genetic disease. Why? Because the family, they know that this is genetic disease because the cousins, they have the same problem. So the mother will tell you that this is genetic testing. I want to know what is the disease. So this is a childhood testing, childhood or genetic testing at childhood. Sometimes you do it in a newborn. The newborn, you can do it in two scenarios. Either the newborn is affected and he's diseased, you want to diagnose. Sometimes you do it as a screening, like what you are doing now. Any newborn will be tested for more than 17 metabolic disease. He's fine, ما عنده أي مشكلة. I want to screen him. But the screening is not in the context of clinic. It's in the context of testing for the community. كان هذا التحليل عام استباقيا. So preemptive testing for the newborn. It's not included here, but it is type of testing in the time of newborn stage. Sometimes you do the testing even before delivery. You take a sample from a fetus. In special situations, circumstances, you do this. There is a risk of this baby to be affected with a genetic disease known in the family. It is a severe disease. I don't want this baby to complete the pregnancy if he's affected. I want to test him prior to ensoulment, قبل نفخ الروح. And if he's affected with a disease that is known in this family, he will be terminated medically. So you do it in the fetus before delivery. You do genetic testing, known as prenatal diagnosis. Let's go further. Sometimes you do genetic testing even before pregnancy. A couple, they plan to get pregnant, they have a risk of disease, severe disease, and they say, we don't want to have an affected fetus from the beginning. So we do genetic testing through IVF, in vitro fertilization, تلقيح خارجي. Then when you have the zygote, we test this zygote for the disease known for this family. If the zygote carries the homozygous mutation known in this family, this zygote, get rid of it. Bring the second one who does not have the disease and get it back to the womb. So you do it before pregnancy, known as PGD, pre-gestational diagnosis or pre-genetic diagnosis. So you test even before pregnancy. هم متزوجين لكن طفل الأنابيب تستبعد الطفرة من اللقائح. Sometimes even we go even further, even before pregnancy, before marriage, we can do genetic testing. Example, فحص الزواج, premarital. However, premarital is a screening. We'll talk about it in the testing for community. But here in the clinic, you don't see this frequently. But this to show you that genetic testing is comprehensive. You can do it at any stage of the life. Okay. We have different strategies to diagnose genetic diseases. We can utilize biochemical testing or cytogenetics or molecular. And this is the introduction that I just introduced. I gave an example for every type. If you talk about diagnosing a genetic disease by biochemical testing, phenylketonuria is a good example. Why phenylketonuria between all these hundreds of metabolic disease? Phenylketonuria is a common, relatively common, خصوصا في الوست, and it is يعني not uncommon in the second thing, phenylketonuria is a history for medicine. It is the second inborn metabolic disease described. Second, before 80 years almost. The concept of inborn metabolic disease was discovered a few years before the discovery of PKU, one of the earliest disease to be described. It's a disease that every patient must be diagnosed from the beginning, because if you miss the patient, baby with PKU, you will end up as mentally retarded person with hyperactivity and normal note, but mentally retarded and hyperactive with seizures and so on. If you diagnose him early and give him a special formula, milk, special milk, he will grow up as a normal person. You don't want to miss this chance. But I chose phenylketonuria to show you how important testing at this stage. After the lecture, I'm ready to have any question. Okay, the second is cytogenetic testing. The common example, Down syndrome, which is even our grandmothers are able to diagnose. This is Mongoli. Mongoli is an obsolete name. And I should find Mongoli. This is the grandmother comment. You use chromosomal analysis to diagnose. The third is molecular testing, which is looking for, you are talking about the level of genes now. You test for on a level of genes, either directly or indirectly. Example of is a spinal muscular atrophy. Do you know spinal muscular atrophy? Have you been through? اكتب spinal muscular atrophy. Google شوف يعني قصص حزينة. It's a disease that affects the neuron in the spinal. The baby will be born normal, has nothing, but these neurons responsible for the muscle will atrophy. Then the muscle will be atrophied, including the respiratory muscle, in a few weeks or a few months or a few years with 3 levels of severity. They need a ventilator. Ventilators are fine, أذكياء, but they cannot breathe by themselves. If you go to hospitals, you may find a patient who is 30 years old, crippled, on a machine, breather, and ventilator. He knows everybody, all the staff is his friends, but he cannot do anything. His body is troubled. This is spinal muscular. Now, recently, we don't even introduce the tube. To diagnose them, we don't, because this is miserable life. Spinal muscular atrophy. It's not uncommon. In our population, it is present. So these are 3 examples for just. Let's start with biochemical testing. Biochemical is a study of amount or activity level of proteins or enzymes. Has nothing to do with the genes, but indirectly reflect the function of the gene. If the gene is functional, you will find these proteins and enzymes normal. If it's not functional or malfunction, you will find it either high or low dependent. Abnormality may indicate change in the DNA that result in a genetic disorder. The tool, the machine, the technology that we use for this biochemical is mass spectrometry, known as tandem mass spectrometry, TMS. This technique was further pushed and developed largely by this country, Mr. Hamad Faisal, in 1991. A paper published by one of our scientists, Hamad, he's retired. He published how to use this technique, which is biochemical technique, nothing to do with the medicine. How to use this to look for the metabolite in our blood or in our urine, and using this profile to know that this patient is abnormal. He has abnormal metabolite. He has some metabolic disorder. And this paper, until now, is cited in every talk about screening for metabolic disease. He's a biochemist, and he utilized this technique as a tool to diagnose medical diseases. The paper يعني مشهورة يعني well known على مستوى العالم. The biochemical testing can be used as diagnosis, as if you have a newborn sick, you do the tandem and you diagnose the biochemical abnormality of this newborn because he's sick. Sometimes you do it for screening, like what you are doing now for every newborn. We do tandem mass spectrometry for every newborn to look for any metabolic disease pre-symptomatic. We want to diagnose before the newborn is sick. Any baby should underwent this prick, to take the blood, then to be introduced in the tandem mass spectrometry machine. The concept is simple. This is it. You put the sample here, it go to the mass spectrometer, the first one and the second one. And this is why we say it in tandem. Tandem يعني بالتعاقب. Tandem. 2 stages. One from one then the other. So there's mass spectrometer number 1 and mass spectrometer number 2. The whole idea that the first spectrometer separate ionized molecule according to their mass. So in this spectrometer, the molecule in the blood or in the urine will be fragmented. Then it will be arranged based on their mass. The heavy will stay here, the light will go here. And you know the mass of every compound. And by knowing the mass, you know that this is phenylalanine. I know the mass of phenylalanine. So this peak is phenylalanine, for example. And this is tyrosine, and you know all the compounds. The second spectrometer will further fragment the compound and categorize them based on their mass and charges. And you end up with the final diagram. This diagram is normal for the normal people. If you put them, they are equal. The peak is almost the same. But if you take a sample from a person, then this is the normal, and you find that this peak, which is with a mass of X, this long, you know that this child, this baby, is accumulating this material in his blood. So this is abnormal. What is this material? Phenylalanine, for example. Oh, this is a case of phenylketonuria. It's accumulating phenylalanine. واضح? So by biochemical test, you diagnose a genetic disease. Highly accurate and very rapid. More than 24 diseases, you can do it in 2 minutes by this technique. وزي ما قلت دكتور محمد راشد, he described the tool, how to use this, how to utilize this tool to diagnose metabolic disease. If you go to 91, 92, read about it, and you will see a lot of discussion. So phenylketonuria is an inherited metabolic disorder. If untreated, lead to mental retardation, seizure disorder, and attention deficit. It affects 1 in 10,000 people. The concept, the whole idea that phenylalanine hydroxylase is deficient. This enzyme is deficient because the gene responsible for this enzyme is mutated. It's not functional. You don't have the enzyme, the phenylalanine will accumulate. You will see it in the tandem result as a huge peak compared to the normal. And you know that this is the case of phenylalanine. We measure the amount of phenylalanine in babies by tandem. Treatment is restricting the phenylalanine from the diet. And you will end up with almost normal baby. If you miss this case, they'll come to you mentally retarded in 1 or 2 years. So we finish with the biochemical with one example, but there is a lot of examples. Almost all inborn metabolic disease, there is a profile, biochemical profile, that either confirm or highly suggest this metabolic disease. But I gave you example just for the concept. The second is cytogenetic testing, can be done on 2 levels. The known karyotyping that you have been through for sure. There is another high resolution type of chromosome analysis known as molecular karyotyping, أو الاسم الآخر CGM microarray, comparative genomic hybridization, CGH microarray. الفكرة إنك تستعمل molecular tools to check the chromosomes. بشرح لكم. Okay, it examines the chromosomes of an individual, including their numbers, forms, and size of chromosomes. It can detect extra or missing copy of chromosomes, large piece of chromosome added or missing, a segment of chromosome rearranged, translocated, inverted. You know these. How to use karyotyping. Karyotyping will tell you about these findings. It frequently we use karyotyping سواء chromosomal karyotyping المعروف or the molecular. If we have a patient with dysmorphic features or mental retardation, we think that maybe he has some problem in his chromosomes. okay? Like, this is an example for how to use cytogenetics. This is an example, baby born, they ask you, you're a physician, I ask you to come to evaluate this child, that your grandmother is, and can diagnose. His hypotonic baby, they told you hypotonic baby, and his eyes is upslanting. It's not normal. So come to see. You saw him? You think maybe he's Down syndrome? Let me confirm by genetic testing. What genetic testing you will do? Chromosome analysis. You did it, and you look at it, and you found that chromosome 21 is 8 copies. So trisomy 21 is Down syndrome. So by this cytogenetics, you diagnose a genetic disease. Now let's go to the molecular type of chromosomal assessment. The problem with karyotyping, a deletion less than 3 megabases, يعني 3000 ملايين حرف. You cannot detect it by karyotyping. So if you have a deletion of 2 million base pair, you cannot see it by chromosomal analysis. But it's not that high resolution tools. And you may miss a lot of deletions, duplication, chromosomal problems if you use only chromosomes. Now the molecular came to solve this problem. I'll try to simplify it for you. The story started with a slide that you prepared, manufactured by, it's a slide manufactured. They bring the whole genome, and they came from the beginning, and they take small segment oligonucleotide, single strand oligonucleotide from the genome, the normal genome. Let's say 25 oligonucleotide sequence, and they single strand, and they put it here in that slide, and they go further, and they take another segment and put it here and here and here. They put this slide with thousands of single-strand pieces of our genome, normal. If you put a sample DNA on this slide, it will hybridize. Every segment will hybridize to its complementary, ولا لا? So, if there is hybridization, indicate that the sample that you put contain the complementary to this area, so this area is present. It's not absent. Okay? This is the concept. You prepare the slide, you bring the patient sample, and you paint it with a red, for example. يسمونه ايش؟ rather fluorescent, red. The patient is painted with red, his whole genome. A normal reference painted with green. And you take these two samples, your patient, that you want to check for deletion, duplication, and the control, and you put it all to this already prepared slide with these segments of our genome. If you have the complementary for this well and the control, which is expected control, because everything is present, and present in the patient sample, so there will be hybridization of green and red. The result is which color? Yellow. أحمر أخضر أصفر. Yellow. So this indicates that this segment, what you know, and you put this segment, you know, if the computer knows that this segment from reflect that area in our genome. If they hybridize equally, it will be yellow. If the control hybridized, but nothing hybridized from the patient sample, indicate what? Absent, yani deletion. Okay? So this area is deleted from the patient. If the opposite, the red is more, it indicates duplication. The material here is duplicated. The red overweigh the green, and you end up with red. So You would put the slide in the computer, and like this, analyzed will give you that we have a deletion in that segment. So if you check the availability, the absence of duplication or deletion in our chromosomes على مستوى molecular level. Sometimes 200 megabase missed, you pick it up by this, compared to 3 million in the chromosomal analysis. Or 5 million, 5 million, 3 million, this is يعني with the hand of the expert يعني cytogeneticist, they may pick up 3 million. أقل منها تسمى micro deletion. You need to do chromosomal comparative genomic hybridization of CGHRA to know it. This is how the diagram would be. This is deletion, this is duplication. Clearly, this is CGHRA. It's a chromosomal analysis, however, molecular chromosomal analysis. It detects copy number variation, deletion or duplication. Duplications, deletions, unbalanced translocation. There is translocation and there is a loss of material, aneuploidies. However, it cannot detect balanced translocation. If you have a segment from one chromosome 1 and chromosome 13 and segment from chromosome 13 and chromosome 1, RSH will not tell you, to tell you normal, because there is no gain, no loss. وحدد لك انها موجوده ولا موجوده بس ما له دخل على المكان. Okay? And this is why we still need the karyotyping القديم. يعني as if you have يعني airplane والkaryotyping bicycle. Common sense. Why do we need to go to bicycle while I have a plane? This is why. Otherwise, we don't need the karyotyping. It is the resolution here is much more than the karyotyping. But if we have a balance, the molecular will not tell you where is the problem. If there is an inversion, will not tell you. Will tell you if there is a gain or loss. This is why we still need karyotyping. Okay, we finished now with the RSAGH. Now let's go to the third level, which is molecular genetic testing. It can be indirect or it could be direct. Indirect, the example is linkage analysis. Direct, allele-specific polynucleotide ASO or direct sequencing. I'll talk about these examples. But it can be used for diagnosis, a patient with possible genetic disease, or sometimes we use it as a screening. زي biochemical, we use it diagnosis, PKU, we use it screening as newborn screening. But the screening, we'll not talk about it because this is a community level. أي شيء screening, we are talking about community level. Today, we are talking about clinic, so we are mainly focusing on diagnosing the disease. Okay? Like, let's go with indirect molecular testing, linkage analysis as an example. So linkage analysis, as you know, there is area in our genome known as DNA polymorphism. It's a short tandem repeat. Tandem يعني بالتعاقب. Tandem mass spectrometry في mass spectrometer واحد mass spectrometer اثنين بالتعاقب tandem. So there is tandem short tandem repeat in our genome. مناطق متكررة in our genome. We can use it as a landmark. The marker locus can be assayed to determine whether an at-risk person has inherited a chromosome sequence that contain a disease causing mutation or an homologous signal. This indirect, we don't examine the sequence itself.
طب شغل اتوقع ما ظل في بطارية بس شغل
هذا
لا هذا
طيب So let me show you this example which will make it easier. This is an example of linkage. You have allele number 1, and you have allele number 2, 3, and 4. This is a family with breast cancer. They suffered from breast cancer. 3 ladies in this family, pedigree, they suffered from breast cancer. They have a child, a girl. This couple, they have a girl, and they came to you and asked you, Doctor, does she have a risk for breast cancer? So we can preemptively screen her and diagnose her. You go back and you study the linkage of this family, and you noticed that any person, any lady inherited the allele number 1, she developed breast cancer. Which indicate that the mutation which caused breast cancer is linked to the allele number 1. So if this girl, when you tested her, she inherited by the tandem repeat, you know that she inherited number 1. She did not inherit number 4 or 3. So she has a risk. So this girl is at a risk of breast cancer. If her allele are, for example, 3 from the father, and she takes 4 from the mother, for example, 3 and 4, there is no risk. So now you don't know what is the gene related to this cancer, but you know that this gene, whatever this gene, is always present in allele number 1. So it will follow allele number 1. Allele number 1 is present, the risk of cancer is present. This is the linkage analysis. So this is indirect. The direct, we have 2 examples, allele specific oligonucleotide, ASO, and we have a direct sequencing, which is the gold standard. Allele specific oligonucleotide is a maneuver that, or technique that you use it in a mutation, in a diseases that is known to be caused by 1 mutation and non-mutation. So you don't need every time to sequence. It is only 1 mutation. زي sickle cell. تذكرون في الجلوتاميت إلى فالين position 6 هي ما في غيرها. Sickle cell. This is the mutation for sickle cell. We don't need to read these letters every time. We can do direct, but without sequencing. And this is it. The idea is to manufacture oligonucleotide specific to this mutation. Oligonucleotide will hybridize to the mutated area. If there's a mutation, this will hybridize to it. And you manufacture another oligonucleotide, 15 to 20 base oligonucleotide sequence, will hybridize to the normal copy. And you paint the one for normal, and you paint the one for mutated. And this is the example. So, the normal, you created oligonucleotide, short oligonucleotide specific to normal allele. And you created another one specific to the mutated allele. And you paint this one with green and this one with yellow. You put the sample of the patient with these 2 probes, and the carrier, they will have both, because he has this one and this one, as the 2. Father and mother, they are carriers, they have both. This girl is wild type. She does not have the green. She does not have the mutated allele. So everything is yellow. However, the affected one is only green. The other brother, the middle, is a carrier, so he has blue, yellow, and green. This is allele specific oligonucleotide. You created oligonucleotide specific to the allele, either normal or abnormal. So the name is allele specific nucleotide. You created a nucleotide specific to this area. So this mutation present, your nucleotide will hybridize to it. It is not present, there will be no hybridization. So this is a type of direct. Now the gold standard now in medical practice is the direct sequencing. Read these letters one by one. Is the process of determining the precise order of nucleotide within a DNA molecule. It includes any method or technology that is used to determine the order of 4 bases, adenine, guanine, cytosine, and thymine, in a strand of DNA. تجيب بهذا الشكل. You see the sequencing paper, you will see it like this. When you do sequencing, there is levels, different levels. Sometimes you know the mutation. I don't need to read or sequence the whole genome, and I know the mutation. This is a common mutation that always comes in this family, in this tribe. So I can do sequencing targeted to this mutation. Sometimes I don't know the mutation, but I know that this is PKU, and there is more than 400 different mutations in the gene of PKU. I don't know which one of them. So I will ask sequencing for the whole gene. Sometimes this is not enough. I know that this patient has a metabolic disease, but I don't know what metabolic disease is it. So there is something known as panel. Panel قائمة contain all the genes responsible for all metabolic disease. It's shorter shorter than the genome for the whole genes. It's part of the genes that are responsible for metabolic diseases together, and you sequence them. Sometimes you have a patient mentally retarded. You don't have any clue. You don't know where to go. So you need to do the whole exome. All the coding segment in our genome has to be sequenced. And this is whole exome. So we started small, bigger. Depend on the question. Whole exome, you sequence all the exons in our genome. Sometimes, most of the mutation is the encoding region in the exons. However, there is a small percentage of mutation in the intronic part between the exons. And this is not covered by exome, so you need to do genome, which will sequence our genome from the first letter to the last letter, including the introns. And this is the most wider genetic testing that you can do all genome sequencing. This is animation, the technique how to do the sequencing. Basically heat will separate the 2 strands, then you put it in 4 different tubes. Then you, as you remember in DNA replication, you add primer, and you add a nucleotide and polymerase enzyme. Every tube from the 4, you add certain type of nucleotide, 1 adenine, 1 guanine, 1 cytosine. Then you add a nucleotide with no hydroxyl group. So after polymerization, when you reach to this one, it will be terminated. Finally, you have different length of strands that you put in an agarose gel, and you can read letter by letter. It is very clear in this animation. I strongly recommend you to see it. The context now of genetic disease, testing for genetic disease, as I told you on the first few words, it could be diagnostic, like what we do in the clinic, and it could be screening, like what we do on the community level. It can be performed for diagnosis of genetic disease, screening of genetic disease. Also, it can be used as research. Diagnostic genetic testing definition now is tests that are usually designed to identify or rule out as accurate as possible a specific genetic or chromosomal condition. Commonly used to confirm a diagnosis when a particular genetic condition is suspected based on physical signs and symptoms and family history. Basically, this is what we are doing in our clinic, genetic clinic. you suspect a genetic disease, you test based on this suspicion. You may use biochemical, you may use molecular, you may use cytogenetic based on that. The result of diagnostic test can influence the person's choice about health care and the management of the disorder, as well as family planning also. طيب, so the diagnosis of genetic testing is, we are talking about the clinic. You diagnose in the clinic. In the community, you don't diagnose. In the community, you screen. This is an example. This is a real example. I saw very similar story happened to one patient who was missed. So a baby just born to a healthy consanguineous couple. He was born in a peripheral hospital where newborn screening was not available. Now, newborn screening should be done for every new baby. Every newborn should be tested for this. At one stage, a few years ago, it was sketchy. Some hospital they do it, some hospital they don't do it, especially in the private. So you may have a baby who was not tested. So in this story, in 4 months of age, he has lighter hair color, which is, by the way, one of the signs of PKU. When you have a patient PKU, the family, all their hair black, you will notice that he's blonde. The phenylalanine is important for the pigmentation of the skin. So he will be fair color and with fair hair. So he has lighter hair color than his family, jerky movement of limbs and delayed development at 4 months. He's not able to roll over, which is normal for 4 months. He should roll over. He cannot do anything. He's hypotonic. Mother is worried, but the pediatrician assumed, he did not think about involvement of disease because he assumed that newborn screening done and it exclude the newborn screening, the metabolic disease. At 12, and he said, he reassured them, he said, no, maybe he will catch up, or he need to improve his feeding or something. 12 months of age, severe developmental delay. At 1 year, he should walk, start walking. He's unable to sit, so he's developmental delay. He starts to have seizure disorder, convulsions. At that stage, the physician asked for a gene panel for convulsion. He thinks convulsion is the problem. And he asked for gene panel, which include the genes which lead to convulsion. Unfortunately, the disease was not included in this panel. So he was missed. In 1.5 years, still he has severe developmental delay, seizure disorder. The physician, he requested the whole exome sequencing request and ended up with the diagnosis of PKU at 1.5 years old. Severely delayed, developmentally speech delayed, seizure disorder. So he's a missed case. He should be diagnosed in the first week. The outcome is a child with moderate to severe degree of mental retardation and attention deficit hyperactivity. What should be the correct scenario? Newborn screening should be done for all newborns. You solve the problem. You will not miss any cases. If you do this, star 1 اللي هي هتبدأ له you will start the special diet and he will be normal. Sometimes star 1, when you have the biochemical suggestive PKU, the next step you want to confirm it by genetic test, also to prevent next pregnancy from being affected. So you ask for genetic confirmation. And you will start double star, you will start treatment, feeding, and special diet, and you save this baby. If you miss this stage, the physician in the second visit at 4 months, he's a sick newborn, even if he did newborn screening the first time, even if he did it, you should repeat it for sick newborn or sick infant. You do tell him, if if you do it, you will pick it up. So it was missed at this stage. At 1 year of age, this is a clinical decision. He thought, I will go to seizure panel. Probably the best thing is to do WES at that stage, to try to diagnose as early as possible the problem. This is what happened. This baby was delayed outcome. If you go with the right sequence, you end up with almost normal child. Screening for genetic disease. طبعا هي التست that usually designed to detect treatable human disease in their pre-symptomatic stage or a carrier status of any target genetic variant can be done on different levels, either family genetic screening or population genetic screening, and this we'll discuss it inshallah in the next lecture about genetic testing in community, in the community. And by this I conclude. Thank you very much. If you have any question. I don't know.